across holes, we get that change in the heart sounds that we just talked about, but sometimes in the pants or panties, they also include what kind of murmur you get. So the murmur you get is a pseudo murmur. There's not actually a problem with the pulmonic valve, but what do you think that extra blood is doing?
Creating turbulence.
It's creating, yeah, the extra blood's creating turbulence, and it's causing a fake pulmonic stenosis murmur. So it's that extra blood is putting a little strain and swooshing sound as it goes across the pulmonic valve. So it gives you a fake pulmonic stenosis murmur. And the way that's described is a crescendo decrescendo or a systolic ejection murmur. It's because it's being ejected out of the valve, we call that ejection murmur. It's exactly the same description of the aortic stenosis murmur, except we're on the right side of the heart with this extra blood flow. So you're going to hear it, and you might even get asked a question like, where are you going to hear this murmur that goes along with this big slit of the S2 with a large ASD? You're going to hear it in the second intercostal space at the left sternal border, whereas aortic stenosis you'll hear at the right sternal border, because the aortic valve is over here on the right side, and the pulmonic valve more on the left side. Okay? So that's another thing to remember. We'll get used to what that sounds like later, but that's the murmur that you get. It's a fake murmur. There's actually nothing wrong with the pulmonic valve necessarily. Okay, the prognosis, it's too high. If the pulmonary pressure becomes greater than the systemic pressure, obviously we don't want high pressure in the pulmonary artery system. If you try and treat them with vasodilator medication and you cannot dilate the pulmonary artery because it got so stiff from all this pressure, it's permanent, that's isomegra syndrome. They try giving oxygen and that doesn't help. If they're desatting still, then that would be a poor prognosis. If the mitral valve affected, if the ASD is so large, remember I told you that it can go down the septum and it affect the valves that attach to the interventricular septum, the papillary muscles, and remember from your anatomy, if it affects that, you also have mitral regurgitation, you can get heart failure right away, because now you have problems both on the left side of the heart and the right side of the heart, so that would increase your chances of a problem. Because if the papillary muscle isn't there and you have wide open mitral regurgitation or like a flail leaflet, or it's just the valve is disrupted from this hole in the heart, much more serious. So fortunately that's much rarer, ostium primum instead of ostium secundum, and ASD is just a general word for any of those holes. Atrial septal defect could be any of those three things I told you about. Most common is actually they said secundum is most common compared to primum, but patent ring ovale is quite common. We don't know because most people are asymptomatic if it's small. They don't get these problems. Okay, the treatment is to decide when you should close it. You don't have to do it when they're first born like you do with tetralogy Fallot. But if you close when they're young, before they're 25 years old, it helps. If you wait till they're 40, there's less chance they'll have atrial arrhythmias from that. But after 40, there's always going to be a little strain on the right side of the heart from this long-term blood leaking there. So pretty much can do it anytime. Now they probably do it a lot earlier because of being able to put, when the baby's, it's safe to do a catheterization on the baby, and you might put an occluder in there because it's a bigger deal to open them up and so. Okay, so that's Amplatzer is a brand name of an occluder. You don't need subacute bacterial endocarditis prophylaxis. That's antibiotics for dental work. Obviously, babies don't need that, but because they don't have teeth yet. But for children, you don't have to because it's not cyanotic heart disease. So the recommendations changed for this, and this is a PANCE question too about who should get bacterial endocarditis prophylaxis and who should not. It's on some slides later. We'll be talking a whole lecture on inflammation and infection, so I'm not going to talk more about that right now. VSD is a hole in the bottom of the heart between the left and the right ventricle, and it can really vary in size. And so the sound that makes, that's usually it closes on its own. I don't know why that one closes easier than the other one, but it does. I only saw one in adult cardiology. We had a pediatric cardiologist at Cleveland Clinic, but so the sound that a VSD makes, and they can close it with an occluder or they can open the chest. Not the preferred thing to do a median sternotomy and split the chest open, just trouble to fix that. So again, these other procedures are becoming preferred. So at first, you same thing as the ASD, left to right shunt, because the pressure is much greater on the right ventricle than the left ventricle than the right ventricle. So the blood will go from the left side to the right. The right ventricle gets larger to accommodate all that volume. Pulmonary artery hypertension occurs. All this is similar to the ASD. And then when you get reversal of the shunt from left to right to left, that's when you have problems, and systemic desaturation. Okay? Because your oxygenated blood, where's your oxygenated blood at?
Left side.
Yeah, but it's no longer going where it's supposed to go, because it's going across the shunt instead of going out the aorta to your body. It's going over to the right ventricle to pick up oxygen again, but it already picked up oxygen, but it's not going out the aorta the way it's supposed to. So if you get systemic desaturation and cyanosis, so a VSD can become cyanotic, but it has to be really large and ongoing for a while. ASD is usually not cyanotic until you would have the reversal of the shunt.
You have that left right shunt. Is that just decreasing efficiency really because that oxygenated blood is going back to the lungs again, or does it
Yeah.
cause any other real?
It does decrease efficiency a little bit.
Okay.
Yeah. Okay. So they get the problem, they get right ventricular failure, not left because of the volume. Remember the right ventricle is very thin, the left ventricle, the muscle is very thick. So that's why it's pushing it over to the other side. Okay, now here's what a VSD exam looks like. Hyperdynamic recording, because even though it's not going across a valve, and it's valves usually that make heart murmurs when they change the way the valve. But instead, you have all this 100 millimeters of mercury being pushed across some of it, not all of it, because it's just a hole, some of it's still going out the aorta. So when it pushes over to there, it makes the chest vibrate and you get a thrill. And the way, here, stand up, Pop. The way you feel for a thrill is you put your hand really hard and you push like that. See, turn around. You push really hard like that. I put my hands up, I'm getting dizzy.
No.
I put my hands on both sides of the chest, and you feel like that, and you go all over it. And sometimes it'll radiate all the way through to the back. That's the way to feel the thrill. You know, go like this. You have to put your hand in there and you feel that thing. So you can see them through people's shirts when they have that. Where did I leave my clicker? I got so excited. Anyways, so you get a loud systolic murmur because it's when the heart squeezes that systole, correct, and relaxes that diastole, no sound in diastole. So it's systole when the left ventricle squeezes and it makes that shunt across going from the left side to the right, and you feel the thrill, the heartbeat, and you hear a loud murmur. Usually they're grade 4. We'll talk about grading when we do our heart sounds lecture. I won't tell you today about that. And when pulmonary hypertension develops, the murmur gets softer because now we have the blood starting to change direction and go from right to left. So you're not going to have as violent of a movement of the blood, but you're going to have bigger problems. So the murmur doesn't tell you that it's not the louder the murmur, the worse the problem is. You're worried when it gets softer. Can't make that. And they can have clubbing of the fingers, which means they're kind of rounded and bluish. The clubbing from that long-term cyanotic, that's your body trying to grow more capillaries and tissues there. Okay, there's another picture of an occluder. So most of them close by the time spontaneously without any intervention. So they should do them pretty young. And the 18-year-old I had that came to see me that wanted a cosmetic, and his VSD must have been so small it didn't cause a enlargement of his RV or gradient, so they just elected to keep following him with echocardiograms. That's the right thing to do. So you go by the numbers and the measurement. What's the pressure in the right side? What's the pressure in the left side of the heart? You tell all that from the echo. How big is the hole? That sort of thing. So it doesn't necessarily have to be closed. Okay, prognosis, it can go to normal once you fix it. Cardiomegaly means heart enlargement. It's a child's stunted growth from this kind of problem. They'll catch up. So any of these things, they should see a cardiologist for the rest of their life. They've had something done to make sure everything's okay. Maybe not even once a year once they're fixed. So that has a good prognosis. ASD has a good prognosis if it's fixed. So these things are left and not treated. So maybe other countries where they might not have all this technology, you might pick up on some kids that weren't doing well, that had undiagnosed congenital heart disease. Fortunately, it's not that common. Remember from the very first slide was what percent of?
0.8.
It was really small amounts, but it's your baby, it's 100%. Granted.
Oh. Can they do this endovascularly, or do they have to open them up?
No, they can do it, and they can do it, you know, in a vascular procedure. That's what's so cool about almost all this stuff. It's fixable. There's a bunch of names for aortic stenosis, and you can see that if it's a bicuspid, remember which valve normally has two leaflets? The mitral valve, and the rest of them all have three. So when what happens, it just didn't separate. So if you were born with this, it was fused, it makes it not able to open up completely. How wide is the aorta? Remember how many centimeters? Don't remember? Did Dr. King didn't tell you? It's about up to 4 centimeters normally, 2 to 4 centimeters the size of the aorta. So if the valve can't open the whole 4 centimeters wide open so the blood can go past it, then you have a reduction in the valve area. The valve area is actually the open part, the open valve area. So they might call it different things. Bicuspid aortic stenosis would be a congenital problem. I mean the same thing. Okay, so obviously you have turbulent flow, and it makes a great noise when it goes past there, and you're all going to hear that when you start your clinicals. Tons of aortic stenosis because we're living longer, and you can tolerate it for a number of years. So you'll see this in adults. Children don't get much symptoms from the aortic valve when they're little, so it gets thick and calcified and narrowed. Okay, so kids are okay with it because remember I told you their job in infants is breathing, not running. As they get older, there's enough blood getting past it out of their heart, and it doesn't cause a right-sided problem. It causes some difficulty for the left ventricle because the left ventricle has to push pressure against that to get up past that valve. So when it pushes that pressure, the left ventricle thickens over time. Not the right ventricle. This is not a shunt, right? We're just talking about a valve that blood can't get out of their heart. So it's the left ventricle that gets thicker. So the children their left ventricle is not dominant, and it takes a number of years. You can see the changes in the EKG. So children, they do okay with the aortic stenosis. It takes a long time, the 5th to the 6th decade, before they present and they have symptoms from the aortic stenosis. These adults, and they need aortic valve repair, replacement. And sometimes aortic regurgitation is the same thing as aortic insufficiency. That means a leaky valve. So sometimes, because it doesn't close normally, sometimes blood will leak back through, and it leaks down back into the left ventricle, and we will talk about how to listen for aortic regurgitation. I'm not going to show you right now. And the pathognomonic murmur that it makes. And once you hear one, you'll never forget it. So I was thinking about trying to get some of my patients to come, but I felt bad about asking to drive. Our practice is 35 miles from here, so 40 miles, it's more like 40, downtown Naples. Yeah, so I'm under 80 miles round trip for 80-year-old patients. And yes.
I think they know left ventricle gets quicker.
Hypertrophy is left ventricular thickening. Yes, good pickup. Okay, so symptoms is shortness of breath, chest pain, because where are the coronary arteries? Where do they come out? By the aortic valve. So if you have stenosis of the aortic valve, it can actually impinge on the coronary arteries and get chest pain. You know, like a pseudo heart attack pain. They can get infected, and they can have sudden death from the valve blocking off and having such low blood pressure that they have syncope. Okay, so it sounds just like that other murmur that I described you, the pulmonic stenosis murmur, the fake one from all that extra blood from the ASD going past the pulmonic valve. The aortic valve, it's a systolic ejection murmur because the blood's being ejected out of the heart. We'll talk about that sound more, so don't worry about memorizing all that too much. The A2 is the first component of the second heart sounds, A2P2. So it gets soft because the valve, actually, as it gets worse, it gets soft because it doesn't make much sound when it closes because it doesn't move very much. It's all stiff. And you might have a leaky murmur sound, which we'll talk about. And you might have a click sound as it's kind of moving apart. Complications, infection, leaky valve, Anything that disrupts connective tissue, did you know that if you smoke, you get wrinkles and it breaks down connective tissue in your body? It also breaks down connective tissue. That's what heart valves are made of. The skeleton of your heart is connective tissue. So if you smoke, that will also worsen the problem, make it leak. High cholesterol deposits in there. We tell our patients not only do we give them statins for aortic stenosis, statins are medicines that lower your cholesterol. We tell them not to take, we cut their calcium dose in half. If they're taking it for osteoporosis or as a supplement, because they may have some component. Dr. Toronto's an expert in aortic stenosis. And we usually give beta blockers to reduce the work of the heart. Beta blockers are medicines that ward off adrenaline and they slow down the heart rate. We're going to have a whole lecture on cardiac drugs, so don't panic too much about all these new terms I gave you today. Okay, just kind of marinate it, and we'll go over it lots and lots more. I'll talk about the murmurs a whole lot more. I just want to get through a little bit about each of these congenital defects. Okay, don't panic. You're like, oh my God. Physiology, the drugs, it's going to be fine. Okay, really not that many. I did give you some numbers here because I just want to give you an idea of what is a gradient. A gradient is when there's a difference on either side of the valve. So when your heart left ventricle contracts, you got 100 millimeters of pressure. What do you think the pressure is on the other side of the? Once it opens, the valve opens, and you what's the pressure in the aorta as it leaves? It's the same as it gets down here to your axillary artery, right? When you check for someone's blood pressure, the brachial artery is still 100 millimeters of mercury, right? You haven't lost any pressure, but you have a gradient. You have a difference in pressure if that valve is stenotic and you lost some of your pressure coming out. That's why you pass out. So the difference between the pressure just before the valve and just after the valve, when it first squeezes, if there's a gradient, there's a difference in pressure. The higher it is, the worse it is. So severe is 40 millimeters of mercury difference. It should be the zero. It should be the same. There shouldn't be any gradient. Your valves completely open up. You're completely pliable, open up, and the pressure's the same. But it's not. And so when that valve's open, pressure's lower on the other side. That's why you pass out, get lightheaded with severe aortic stenosis. A really severe is 80 to 100 millimeters of mercury difference. So you have to be careful giving them things, blood pressure medicine that is really effective, like ACE inhibitors. We'll learn about what those are in a few more lectures. But those kind of drugs are so effective that you drop the pressure so low on the inside of the valve that you get literally hypotensive because you have this gradient. You already lost a bunch of pressure there. So that can be dangerous. So we like to use beta blockers, which are not as potent as ACE inhibitors. The valve area, remember I told you the open part of the valve, instead of being 2, 3, or up to 4 the maximum millimeters wide, centimeters wide. The valve now is only maybe 1 centimeter of area for the blood to get through. So that would be severe aortic stenosis. So the point I want to make this, okay, without remembering numbers, is a problem increasing or decreasing gradient? Increasing gradient, that's bad. Okay, aortic stenosis, is the problem decreasing valve area or increasing valve area? Decreasing. So the problem is increasing gradient and decreasing valve area. That's the thing that I want you to remember about what aortic stenosis is, not the numbers. You don't have to tell me that 80 millimeters is aortic stenosis, but you have to know that if you have an increasing gradient and a decreasing valve area, that's the lesion. That would mean you understand what's happening there, okay? And you'll have to know what the murmur is, even though it's hard. We're going to listen to some cases, but not today. Not today. Okay, so there's all kinds of ways to fix it. You can open the chest and you can put in either a bioprosthetic valve, which is a tissue valve made from, the leaflets are made from the bovine equine, or porcine. Porcine is pig, bovine cow, equine horse, pericardial tissue. They soak them until they're not reactive, and then they sew them onto a strut. And they have some pictures in here. So the valvular heart lecture we're going to have this week, I will show you pictures of what those different valves look like. Okay, and the really exciting thing is a TAVR, the transcatheter aortic valve replacement. They go retrograde. They put a catheter in the aorta side, in the arterial side, and they go retrograde backwards up the aorta. They give drugs to speed up the heart really fast, so there's less cardiac output. Your heart squeezes hard. It doesn't have time to fill and less blood comes out, so you have less flow going against you. They go ahead and they deploy the valve. There's tons of videos. I highly recommend you go and you watch this because your patients are going to be asking about this. It's very commonplace now. But for people that are not candidates for open heart surgery and people are living longer and longer, and they say they have severe COPD, they're 94 years old, and they're going to die from aortic stenosis because they are, what's that light flash?
It's a fire alarm.
Do we have to leave? Yes. So they can't have surgery because they're too sick or too old, and they're going to die from it because they're passing out and they're so short of breath and they got chest pain from the aortic stenosis and their life's worth living, then they can have this procedure that just takes short time to deploy a new aortic valve backwards. It just squishes the old one out of place and drops this one in there, no sewing, nothing. It's really exciting. So we're starting to do those in Southwest Florida, but they do them lots more in the big centers. So I highly recommend just go to YouTube and just put DAVR in there and watch one of these. Okay? Don't have time. Cardiology is so vast. There are like 8 specialties within cardiology. We're trying to touch upon a lot of them. So it's just tip of the iceberg stuff we're doing here. Good prognosis. And like I said, it's much later. You can wait till you're adult to do that. Pulmonic valve stenosis is really, I hear about this a lot, and sometimes there's even a student in the class and their baby was told they have this. So pulmonic valve stenosis, 2 different pictures of it. Here's showing what really happens. It gets thick like that, circle around it, and there that's just showing some difficulty of the blood getting through there because the valves are pliable. They were thickened like that before they were born. So to fix that, the best way to do it is they just dilate it. They put a balloon in there. And they can go back a second time and do it until it's better. Now, the important thing you have to remember is one of the 4 things in tetralogy, which tetralogy means 4. So you have to remember the 4 lesions of tetralogy below. Pulmonary stenosis is 1. They can also occur isolated. Babies can have that and not have tetralogy below. So the main thing is they dilate. They put this thing in there and they just push it right through there. And it helps a lot. And they can go back and do it again. So it's outflow tract. Remember I told you what the outflow tract was? The blood going out the pulmonary artery. So from the right ventricle through the valve to the pulmonic valve, that's the outflow tract. Inside is not the outflow tract. Between the right atrium and the right ventricle is not the outflow tract. That's just a collecting system. Symptoms, obviously you can see why would you get short of breath? That's the main symptom of pulmonary hypertension. Shortness of breath, right? What's the main symptom of essential hypertension or systemic hypertension? None. People don't know they have hypopressure, but with pulmonary hypertension they do. They get short of breath. If you don't deliver the proper amount of blood to the pulmonary bed, you get short of breath. Okay, again, just like with the aortic stenosis, you can for VSD, you can feel a thrill. Whenever you have stenosis, calcium, thickening, difficulty closing valves, it gives you a thrill. Turbulence equals vibration. So you want to feel for a thrill? Well, let's talk about this murmur more in our murmur lecture, okay? I don't want to spend too much time on the physiology today. Don't worry about the EKG because you don't know anything about that yet. We'll talk about those findings on the EKG course. But you could have questions like that on the pants, and the x-ray is obvious, and the echo will definitely show you what's going on. There's a treatment, see the balloon? Laser doesn't work. Here, right here. So they went from the vena cava, they put the balloon right in the valve, they squished it open, well, better. Okay. Coarctation of the aorta is just constriction of the aorta. It's congenital. It's beyond the blood vessels that go up to your head. You see the constriction right there? Normal. Everyone see it? Okay. There's some classic things that go with that. They like to ask questions about coarc because they want you to know that you get a discrepancy in the pulses between the upper extremities and the lower, because the blood flow is okay to the upper extremity, but not to the lower. It is sometimes associated with aortic valve stenosis. It's diagnosed in infancy and childhood. So it's just distal to the left subclavian artery. Sometimes it occurs with patent ductus arteriosus. That's not a good thing when you have two blockages like that. Sometimes with Turner syndrome, there's coarctation of the aorta. And Turner syndrome, you'll talk about that later in the endocrine part. The chromosomal abnormality in females, yeah.
So that would be the origination of the radial femoral pulse lag we were saying
Yes.
before?
It would be coarctation could cause a radiofemoral pulse lag. And they like to ask you about this in the pants. It's not that common, but it has a really cool, I've seen it a bunch of times. I've seen the x-ray signs, which I'm going to show you. So upper extremity forceful pulses, lower extremity weak pulse lag. The reason why it makes a continuous murmur is because you get a whole bunch of blood vessels that grow around that blockage. The body tries to heal itself, and that gives you a sound that you hear. But when you have sound in blood vessels making murmurs, it's you hear it both systole and diastole. So it's like roar, 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 roar. So it sounds continuous, rather than being ejected through a valve. You can get aneurysms in the brain, Barry aneurysms, little round aneurysms because of the high blood pressure. You can get thickening of the heart muscle from just straining it against that. Just think of that. It's not the valve this time, it's beyond the valve, and it's so tight that happens. And a fourth heart sound, we'll talk about fourth heart sounds when we do our heart sound lecture. Okay, so the thing that's interesting is the chest x-ray. You get rib notching. Rib notching is because you have high blood pressure of the intercostal arteries. The intercostal arteries lie on the bottom of the ribs, and you're going to need to know where the veins, the arteries, and the nerves are, because you're going to be sticking tubes in between the ribs to do synthesis for pneumothoracx, that kind of thing. We'll practice that in lab, not on each other, on models or ribs. I've running ribs and stuff to do that kind of thing. So anyways, what happens is this is a figure of 3 sign from the coarctation of the aorta. It goes in and then it goes out. This is not a really great picture to see it, but the rib notching is really good on this. Push this red thing, but if you look here really carefully, you see at the bottom of the ribs where it goes up like that? You see this little dent right there? Mm-hmm. And that's because it eroded the bone away. You put pressure on a bone from the high blood pressure in the vessel. Think of how your braces, or anyone ever have braces on their teeth? It erodes the bone because you put that pressure on it, you pull it over with the wire, and it wears away the bone, and then it moves into the new place. Well, there's nothing to move here, but it eroded the high blood pressure along the bottom of the rib, wore the bone away, and you get rib notching. So you can see that in a couple places. Subtle, but it's there. You all get excited when you see that. So this one, they want to do antibiotic prophylaxis. Balloon dilatation is the treatment of choice. Open it up. You want to wait till they're older. They can tolerate it for a while, but you don't want to wait too long, because when they start going forward. So I don't care about numbers like 75% success rate. I don't care about that. I just want you to know that that's the treatment of choice for what other lesions did we just talk about? You want to use a balloon for? Stenosis of pulmonary artery. With that, it doesn't work so well for the aortic valve, because the aortic valve is under a huge amount of pressure compared to the pulmonic valve. So the aortic valve, you really need to replace it. And repair doesn't work so good. They don't repair it; they just replace it. But you can repair pulmonic things, and you can do a balloon on this. So there's an angioplasty of a coarct. They put a balloon through there and blew it up, and they reduce it. A lot of times with coarctation, hypertension remains. So you have to treat them for that. So it's poor, obviously. If it's proximal to a patent ductus arteriosus, that's a problem. So they actually keep if the baby has a patent ductus, they actually keep that open, so the blood has a way to be shunted through that patent ductus arteriosus. You get, even though it goes out the pulmonary artery, some of that blood goes through a patent ductus arteriosus and then goes down the aorta. So you get a little more blood going to the rest of the body. So a patent ductus is good for cork in a baby. And complications, if it because of the high pressure in the aorta, it could dissect, split into layers where blood goes between the layers of the aorta more commonly when you have that. Getting an infection, rupturing, because of the high blood pressure, remember the circle of Willis is in the brain? You get aneurysms and have strokes from that. And only half of adults, once it's fixed, have normal blood pressure afterwards. So just remember that's a complication of it. You have brain aneurysms, persistent hypertension, even after post-repair. You could have endocarditis and infection. So you should remember some of the possible complications. And the signs, the pulse lag, the chest x-ray, classic signs. A patent ductus arteriosus is what we all have because there's a little bit of blood goes to the lungs because the baby has to have blood in the lungs in order for the lungs have to get oxygen themselves and develop in utero. But the majority of the blood goes out the pulmonary artery and then into the central circulation in utero, right? Where's it going to go? You can't send it all the lungs. The baby's not breathing, so if you flooded the lungs with blood and they're not breathing in or out, then they would die. So it goes. The PDA is a necessary thing. And that closes shortly after birth. When the baby takes a deep breath and cries and then pink up, it quits going through there. And it just goes out the aorta. It closes from the change of the pressure. All of a sudden you have all this pressure in the right ventricle you didn't have before. They breathe, so it all happens. And it gives, again, remember I told you get continuous murmurs when you're talking about blood vessels having a problem in them? And you see why it's heard best in the left second intercostal space? This is where it would be. So the aorta turns and goes, and you're going to hear it over there. So it's a rough lob machinery type thing, and this is something I've seen before. It envelopes the second heart sound. You can't use it when the heart's trying to go bump, 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 bump. But all you hear is sound because it's a vascular murmur. So it's going to be systole and diastole. So you see that on a baby who's maybe not eating good, that kind of thing, not getting enough blood to his body. When you hear that kind of murmur, then you would do an echocardiogram immediately. Prognosis. They can do things like give medications and help change it. But a friend of mine that works in pediatric cardiovascular surgery said they go by the bedside. They make a little hole in that baby's chest, and they put a little clip on there, and they close that. It gets so close to the surface, they just fix it at the bedside. So they used to give indomethacin and things that would maybe make it close. But you don't really want to open the whole chest, but they can make a small incision. I suppose they use a local anesthetic and they fix that. So it was amazing to me that they did that. Yeah, that's something you want to have. They do all kinds of things to babies, believe me. It's not funny. So there I told you about they can use indomethacin or intravenous ibuprofen. That's Motrin, but IV form. That might make that close out. Okay. So open surgical ligation is what I just described to you, a clip done in the neonatal intensive care. So they expect you on the pants to know what patent ductus arteriosus is. So you all remember what it's there for, right? You've got to shunt the blood from the lungs to the systemic circulation. It's been oxygenated by what? The blood. Well, yeah, placenta. You picked up your oxygen from your mama, who's increased her blood flow how much? Yeah, like 40%. So she's giving that all to the baby, all that extra oxygen, and the baby doesn't need its most. They do take some rudimentary breaths. If anyone had a baby in here, your baby breathes sometimes. It just like takes a breath. It's the weirdest feeling. But that's why they have mucus and stuff in there. They swallow amniotic fluid, they breathe some of it in, and they suction it out when it's born. But they do a little practice breathing sometimes. I didn't make that up. That's true. Okay. Got to memorize this. You've got to memorize this. 4 things to tetralogy below. This is cyanotic heart disease. This is bad. This has to be fixed, and it has to be fixed soon. Something like 90% of them die if it's not fixed by, I forget how many years, but it gets worse. Anyway, our former program director, Dr. Tina, her son had this. He's doing great. So this is fixable. They started fixing this in the, I think it was 1950-something, they started doing these operations to fix this. It was before they had bypass surgery, so there's a whole lot to do. So the 4 lesions, pulmonic stenosis, okay? So that's got to be fixed. They have an overriding aorta, meaning the aorta is not over the left ventricular outflow tract, it's also over the right ventricular outflow tract. So you've got a big valve problem there, you've got a big hole in your heart. You have a huge VSD, so you've got this big hole in the center of the heart. You've got a VSD, you've got overriding aorta, you have pulmonic stenosis, and then of course you have right ventricular hypertrophy because this was present before the baby was born, and the baby's heart is beating, and the right ventricle is already prominent, but now it's even more prominent. It's working harder because you have what kind of a shunt going on in the heart. You got a left to right shunt, you've got all this blood going over to the right side, and the right ventricle is working harder than it needs to before they're born, and because normally before they're born, it's not pumping blood to the lungs. The left ventricle is not that prominent either, but anyways, you get right ventricular hypertrophy because it's a cyanotic disease. And once they're born, they have to do extra work too to get blood to their lungs. And if they're not able to get enough blood to their lungs because it's being shunted back and forth. So you've got to memorize these 4 things. You will definitely get asked that. There's a picture of it, pulmonic stenosis. Doesn't really show you it, but you have to remember that's narrowed. Here's the aorta, and it's over the right ventricle and it's over the left ventricle. We're kind of missing an interventricular septum here. See why it's cyanotic? Okay. So just work on memorizing that. And they call it TET spells, and the baby might squat to try and increase the venous return and breathe better. Yes. No, it's way too complex. Yeah, I know there's some that they fix maybe stenosis and different things, but you can't. And they're getting their oxygen from their mother in utero, and they're not doing any extra work, totally parasitic, getting their food, the oxygen. So they're not dying in utero. Once they're born, they have to do the work of breathing and eating. Eating's a lot of work for a baby. That they become cyanotic right away. So you wouldn't want any risk like that. And they get, remember the very first picture of the baby? Was that normal? That very first picture of the newborn baby? On the very first slide, was that a normal baby or not? It was normal because the only thing that was purple was what? His feet. His beautiful pink face and everything. So this baby has perioral cyanosis. That's not normal if they're blue around their mouth like that. Or if they have cyanosis on their chest, or fingers, and many times babies are born, their fingers and toes are purple. Sometimes the whole baby's purple for a second, so they take a breath. Yes? Somebody's a question over here? No? Okay. Just about done. There's a picture of the clubbing I mentioned before from the cyanotic. So this is much more complicated what this sounds like because we've got more than one lesion mixed up in there. So we'll talk about the heart murmurs when we do a heart sound one, but we have a lot of abnormalities. And the boot-shaped heart is from the cardiomegaly. See how it's shaped like a boot? Round like that. That's not the normal shape. See from your x-ray course. And then the treatment, there's a picture of the patch graft on the pulmonary artery, and they would go through here. So the surgery may have been changed somehow they do it. But they definitely have to dilate the pulmonary artery. They got to close the VSD. Fix the valves. It's open heart surgery. So here's how many don't survive. 30% first year, 75% age 10, and 90% by age 20. Untreated. The prognosis is really pretty good. The very last thing, really common mitral valve prolapse is, the prolapse is when the mitral valve domes up. Instead of just closing, it'll dome up, and it can be either the anterior or the posterior leaflet. I believe this is the posterior leaflet, the way this is shown. So heart would be turned like that, with the left ventricle behind. So the mitral valve, it domes, so when it closes, instead of just closing flat like that, the mitral valve, it goes like that and bows. That's prolapse of the valve. Really common. Some people estimate as much as 10% of the population has this. Doesn't need to be fixed. It can cause symptoms, i.e. some people have palpitations, chest pain. Sometimes they're energetic type A personalities. Nobody really knows why, but it is to be associated with a syndrome of having excess catecholamine, a lot of adrenaline. And one of our classmates last year had microbial prolapse, and she let us listen to the mid-systolic click. So when the valve closes, it's closed click. So you hear a mid-systolic click. From click, bump. So this is the S1. So bump, click, bump. The second bump is the S2. So bump, click, bump. You'll hear a mid-systolic click. If you have mitral regurgitation or leaking of the blood going through there, so you might hear a mitral regurgitation murmur. That's unusual for that to happen, but that's what you observe for. And we don't prophylax that anymore. We used to give antibiotics for mitral prolapse. It's no longer recommended. So when we do our infection lecture, we'll go over the American Heart, American Diabetes, or American Dental Association 2007, I think, recommendations for prophylaxis. You know that for the camps too. You're not going to do that today. Okay, so there's some couple of pearls for you that sometimes I remember being asked what was present at birth. What kind of murmurs, so I put that on there for you to look at, and that's that. So thank you for your attention.
Thank you.
Thank you.
Sorry, I went a little fast, but that was